Good afternoon, everyone. My name is Jessica Solomon Fisher, and on behalf of the Public Health National Center for Innovations, I am pleased to welcome you to today's webinar entitled Transforming Public Health Through Collaboration with Healthcare. Before we begin the presentation, I want to provide a few housekeeping items. Today's 90-minute webinar is being recorded, and all participants will be muted during the presentation to limit background noise. After the presentations have been completed, a question and answer session will commence. Your participation is key to the success of this webinar, and we encourage you to engage with today's presenters. By utilizing the questions panel, you can type in questions at any time during the webinar and during the question and answer sessions. We will do our best to answer all questions asked today. We are hosting this webinar as part of PHNCI's Fall into Learning webinar series to provide the public health field with information on emerging trends and strategies to advance innovations in practice. Today's presentation is the second in the series, where we will focus on the importance of the collaboration between public health and healthcare and learn about two national initiatives aimed at improving population health through reforming of delivery of healthcare services and exchanging information between sectors. Visit our website to view the recording of the first webinar of the series and/or to register for the last webinar taking place on December 12th. Today we have four presenters. Our first presenter is Paul Kunert, the Assistant Vice President for Program Staff at the Robert Wood Johnson Foundation, where he provides leadership and management support across programmatic efforts to build a culture of health. Previously, Paul directed the public health team and the Bridging Health and Healthcare portfolio for the Foundation. Prior to coming to the Foundation in 2012, Paul led both governmental and community-based organizations in order to help people lead healthier lives. He is a pediatric nurse practitioner and holds the Doctor of Nursing Practice and Executive Leadership, as well as a Master of Science in Public Health Nursing degrees from the University of Illinois at Chicago. He was named an RWJF Executive Nurse Fellow in 2004 and became a Fellow in the American Academy of Nursing in 2015. Our second presenter is Vivian Singletary, the Director of the Public Health Informatics Institute, where she guides work to improve health outcomes worldwide by strengthening health practitioners' abilities to use information effectively. Earlier in her career, Vivian spent more than 15 years in leadership positions in supply chain management and information systems implementation for Home Depot and M&M. Vivian holds a Master's of Business Administration degree from Kennesaw State University and is currently pursuing a Juris Master's degree from Emory University School of Law with a focus on global health. Our third presenter is Jim Jellison, the Interim Director of the Practice Support Unit and Senior Informatics Analyst with the Public Health Informatics Institute. He has nearly 20 years of experience evaluating technical and social aspects of health information systems. Jim is an alumnus of the CDC Informatics Fellowship, where he worked with the National Environmental Public Health Tracking Network. Prior to that, he was with the Nashville Health Department in roles related to geographic information systems, surveillance, emergency preparedness, and environmental health. Jim holds a Master of Public Health and Epidemiology from East Tennessee State University and a Bachelor of Arts in Social Sciences from Michigan State University. Our final presenter is Heather Howard, a lecturer at Princeton University's Woodrow Wilson School of Public and International Affairs and director of two Robert Wood Johnson Foundation-funded programs that help states implement health reforms. As a faculty affiliate of Princeton's Center for Health and Well-Being, Heather teaches courses on the Affordable Care Act, state and local health policy, and the social determinants of health. Heather served as New Jersey's Commissioner of Health and Senior Services from 2008 to 2010 and has significant federal experience, having worked as Senator John Corzine's Chief of Staff, as Associate Director of the White House Domestic Policy Council, and Senior Policy Advisor for First Lady Hillary Clinton. As an honors attorney in the U.S. Department of Justice's Antitrust Division Healthcare Task Force and for the U.S. House of Representatives. Heather received her BA from Duke University and her JD from NYU School of Law. After our presenters are finished, participants will walk away with an understanding of the following objectives, and I'll let you all read those to yourselves as I turn it over to Paul.
Thanks so much, Jessica. Appreciate it, and good afternoon, everyone. I want to thank each and every one of you for joining us, taking the time out of your busy days to join this conversation this afternoon, and do want to encourage you as you hear our presentations, if a question comes to mind, please go ahead and jot that into the question box, and we'll try to get as many of those answered later in the discussion as possible. So again, we're exploring this topic of transforming public health through collaboration with healthcare. And for me, starting this, we really have to think about what it is that, what's the problem that we're really trying to solve. And just trying to get the technology to work here. Okay. Kat, if you want to go ahead and advance my slide for me, doesn't seem to be responding. But as we're here in Princeton, we love to use this image of Albert Einstein just to kind of remind us that, we are talking about a system in the U.S. where we pay the most if we compare ourselves to other of our peer nations, and we get the least if we look at health outcomes in terms of population health outcomes. If we look at the issue of inequities and the tremendous disparities in health outcomes across our communities and our country. And what Don Berwick and others have taught us is that systems are designed to get the results that they get. And so this idea of Einstein's that we really have to kind of change our mental framework is something that's very important as we think about the problem that we're trying to solve in terms of improving health. So if we go to the next slide, here at the Robert Wood Johnson Foundation in 2014, we had gone through a strategic planning process, examined all the trends and data, looked at and reflected on our own practice, and came to the conclusion that we really did need to think about going beyond kind of incremental projects and improvements and really trying to shift the conversation in the United States. And so we've captured that as this notion of trying to build a culture of health that would really enable all in our diverse society to lead healthier lives now and for generations to come. So again, trying to think much more broadly about solving this issue of improving health and health care. If we go to the next slide, part of what we got feedback on as we rolled out this vision was that, the vision is very inspiring. I think particularly for those of us that have been in health and health care, it's kind of speaking to the choir. But how do we really get traction around this vision of a culture of health? And through engaging probably more than 1,000 people and from a variety of different sectors and organizations across the country, we came up with this framework that we call the Culture of Health Action Framework. And you'll note a couple of things here that I think are key concepts as we think about trying to move and build a culture of health. First is that surrounding the action framework and kind of the key component of it is the notion of equity. And that in fact to interact in any of these areas within the framework, we have to do so with an equity lens. Secondly, the action areas within the framework are touching each other and overlapping with each other. And that's because these are interdependent activities. And as you think about this and explore it, you can see that the notion of making health a shared value in our society definitely connects with all of these other action areas: fostering cross-sector collaboration, creating healthier, more equitable communities, and strengthening integration of health services and systems. All of these interacting to get to the outcome of improved population health and well-being, as well as equity. So we're seeing this, as many folks do, as thinking about it as a generational activity, so something that's going to be 20 to 30 years in the making. But we feel that at this point in time, it's kind of focusing in these 4 areas of action that are so important in terms of making progress toward building a culture of health. And today we're talking about really activities that are primarily in this action area 2 of fostering cross-sector collaboration. So if we go to the next slide, you see that in this slide, it is trying to break out kind of the community health improvement process into a set of activities that include engagement, assessment, planning, action, and then measuring, evaluating, and adjusting based on the feedback and the progress. So I think all of us from either our clinical work or our community health work have an orientation toward this type of process. And what I would suggest to you is that in each of these areas, there are opportunities for collaboration. But oftentimes, the idea of collaboration is kind of left at the level of a platitude. We should collaborate. We must collaborate. So what exactly does it mean to collaborate? If we go to the next slide, this slide is based on the work of Arthur Himmelman, who has kind of broken out collaborative activities into a continuum across at least 4 areas. So if we click, the next component comes up, which is at one end of the continuum on collaboration is networking. In other words, kind of basic information exchange for mutual benefit between organizations. If we click the next activity will come up, which is identified as coordinating. So not only exchanging information, but starting to alter our activities between our organizations, again, to get to mutual benefit and common purpose. If we click another time, we get to another area along the continuum of cooperation. So not only exchanging information, altering activities, but also starting to share resources for mutual benefit and common purpose. And then finally, collaboration in Himmelman's model is described as all of these other activities plus working to enhance the capacity of others. So it's doing all of these things in cooperating, coordinating, and networking, and adding to that the notion of capacity building in kind of mutual assistance in a very deliberative way. So if we go to the next slide, and this is, I'm not going to go through these, it's just to kind of point you toward more information. You'll have access to these slides afterwards. But I have found it really helpful to think about breaking out collaboration into different types, at least these 4 different types, if not even more specificity, in order to kind of match our collaboration with the tasks that we have at hand that we're trying to address, and also to really match the level of organizational involvement and collaboration with the level of trust that actually exists among our organizations within a certain community or region. So I'd invite you to look at this information in more depth and think about whether this is helpful in terms of thinking about the collaborative activities that you may be doing in your community. So if we go to the last slide here, the basic notion is that in order to achieve the kinds of big goals that we're all trying to achieve, we need to do this in more than just thinking about it, more than just kind of imploring each other to do it, but seeking to act together in concrete ways. So before I kind of turn this over to my colleagues for giving you concrete examples of collaboration and kind of along this continuum, A couple of other resources for you if we go to the next slide. So I wanted to share these with you. These are the criteria that we have for our Culture of Health prize communities. So we're really looking at collaborative efforts across sectors that are examples or exemplars, and we now have about 30 of them, and they are inspiring communities that are on the journey to building a culture of health and are meeting in various ways these 6 criteria. So as we talk further this afternoon, we'll probably be talking about collaborative efforts at various places along a journey, and these might be points of reference in terms of how to get started or how to continue to make progress. And then my last slide points to, if we can click to that next one, our cultureofhealth.org website, which gives you more information about the action framework, gives you some of the data that we've been collecting across the country in terms of looking at some of the key drivers of building a culture of health, as well as some of the measures. And we also have some inspiring stories from our communities that point toward what it looks like on the ground. And I know that we're going to find out more about that from my colleagues that will be talking with you this afternoon, and then from you as you participate with your questions. So before I turn it over to Vivian and Jim as our first speakers, I want to do a couple of quick polls. And the first one, just to give you a sense of this, is to answer the question of what sector you work. So if you could select either public health, healthcare, or other, I think we're going to open the poll. And we should start seeing those results come in. So I don't know if we can see the results. So great. It looks like the vast majority of our participants this afternoon are from public health, but thank you so much to our colleagues that are from healthcare and from other sectors. And then if we go to our next and final poll this afternoon, that's going to help us understand where you all are in terms of your work. What's your current level of involvement in sharing data across public health and healthcare? Do you have no involvement, some involvement, or extensive involvement? We'd just like to get a sense of that because indeed one of our first, or our first example is going to be talking about data sharing and infrastructure. So we'll just give another second or two for everyone to select their response. And then if we can go ahead and go to the results. So it looks like, again, a vast majority, 2/3, are having some involvement in sharing data across public health and healthcare. And about 20% of you have pretty extensive involvement in this area. So I think this is one of the areas that we are seeing increasing collaboration among public health and healthcare organizations. And so we also know that there's opportunities for doing even more of that. And with that, I'm going to turn this over to Vivian and Jim to talk about the digital bridge.
All right. Thank you, Paul, for that great lead-in, great presentation. And this just kind of builds upon what you just talked about, the whole notion of collaboration. Next slide, please. All right, so what is Digital Bridge? We'll just kind of kick it off from there. Digital Bridge kicked off this summer earlier as a collaboration, which is funded by the Robert Wood Johnson Foundation, but it is a collaboration between the Public Health Informatics Institute and Deloitte Consulting. And the whole notion behind Digital Bridge is really to improve the flow of information between public health and healthcare. And our goal is to really identify a consistent nationwide and sustainable approach to using this EHR data to improve our approaches to public health surveillance. Our current governance committee that I'll talk a little bit more about includes representatives from several sectors: public health, healthcare delivery systems, and the IT vendors. And so Paul alluded to the notion of collaboration across sectors, but also one of the big keys to Digital Bridge is collaboration even within a sector, and specifically public health. As we know, it's very well know it's federated and decisions are made at the jurisdiction, state and jurisdiction level. So sometimes it's difficult for public health to speak with one voice. And it is this bringing together of public health within Digital Bridge that's really the linchpin in terms of moving this whole initiative forward. I also want to point out that Dr. John Lumpkin is serving as the chair for this governance body that we'll talk a little bit more about as well. And our initial focus for Digital Bridge is focused on electronic case reporting for reportable disease. But the vision, the longer-term vision for Digital Bridge is that this whole effort can be sustained, particularly around the governance structure and how decisions are made for these various sectors, that we can do this in collaboration and continue to move beyond reportable diseases on into non-communicable diseases. So that's the longer-term vision for Digital Bridge. Next slide, please. So I'll show you and talk about the organizational structure for Digital Bridge. As I pointed out, there is the Program Management Office that is managed by Deloitte Consulting and PHAB jointly. Then we have our Governance Committee, which is, again, chaired by Dr. Lumpkin, and it also includes members from the Care Delivery Network, Public Health, and our EHR vendors. And for some of our care delivery networks, we have some of the largest care delivery networks involved, including Health Partners, Kaiser Permanente, and Partners in Healthcare. We have the large EHR vendors involved, including Cerner, Allscripts, Epic, Meditech, and eClinicalWorks. From the public health perspective, we have all of the associations involved, from APHL to ASCO, NACHO, CFTE, ONC, and CDC. So all of the big organizations are represented here within this governance structure. Spawning off of the governance body, we have 4 work groups that are being assembled, one of which has just recently come to a close, which is our requirements work group, which really laid out the functional requirements for making the Digital Bridge happen, this information exchange from EHR to public health. That group has just recently closed. Now we're moving forward with the technical work group that is laying out the technical architecture that will allow, so all of the functional specs and details, technical specs, sorry, about what it takes to make this information exchange occur, and that work group is now in session. They've met about 3 times, and that work group will wrap in the next few weeks and provide for us our technical roadmap for actually enabling this exchange of information during phase 3 of our project. Then our sustainability work group is just about to kick off. And this is really all about how do we continue forward with Digital Bridge? How do we make this a sustainable effort that doesn't just kind of fall into the wayside at the end of phase 3? And then we have a final group that's looking at any legal issues, policy, regulatory issues that may impact this exchange of data. Next slide, please. And I just talked about the governance body members, so I'll just give you a couple of seconds to digest that if you want to quickly read it. But this is also available on our website, which is listed at the top of the page, digitalbridge.us. Okay, next slide, please. So I just want to give you the quick definition of what we're calling electronic case reporting, and this is really the automated generation and transmission of these case reports from the EHR to the public health agencies for review and action. So that's what we're considering these electronic case reports. Next slide, please. And then I'll end before I turn it over to my colleague Jim Jellison to talk in more detail about the Digital Bridge. Just what is the value of electronic case reporting? And really it comes down to making information more complete, more timely, that information flows very quickly from the provider to public health and that action is taken. It'll help improve our surveillance capabilities, improve our ability to detect outbreaks and make a response much quicker, and get those that need to be involved, whether local, state, gather those partners together to make a quicker intervention. Also, one of the big things in terms of value for the provider is really diminishing the burden on the healthcare provider to report, because today it's not automatic. It requires thinking about which diagnosis may or may not be on the reportable conditions list, and then taking a separate effort to make that report to public health. So those are what we see as the value for electronic case reporting. And so now I'm going to turn it over to my colleague, Jim Jellison, to talk about Digital Bridge in a bit more detail. Jim?
Thanks, Vivian. Thank you. Can we go on to the next slide, please? So this is a high-level depiction of the data flow for electronic case reporting. And but before I jump into it, I just want to acknowledge that this Digital Bridge process is not just bringing together the stakeholders that Vivian described, but also tools and resources that they've already developed. We're trying to make this electronic case reporting approach easy for healthcare providers, easy for electronic health record developers and vendors, and we're also trying to take advantage of resources that have already been developed by partners in public health. And I'll mention them again, but in case you're wondering about things like the Reportable Conditions Knowledge Management System and APHL's AIMS platform, they're in the mix as are other resources. So thinking about this process, if you look at the left, you'll see a dashed vertical line that indicates there's a precondition that happens here. And what happens is practitioners at the state and local public health levels utilize this system called the Reportable Conditions Knowledge Management System to define their reporting criteria. And the Reportable Conditions Knowledge Management System, or RCKMS, lives or is envisioned to live in this decision support layer that will serve as an intermediary or the bridge between healthcare and public health. And what it's doing as a precursor for electronic case reporting is providing trigger criteria, the criteria that will trigger an electronic case report to healthcare providers. So it can be so that trigger criteria can be imported into the electronic health record systems of healthcare providers. So then once that's in place, healthcare can go about providing patient care and utilizing their electronic health record system. And when that system sees current patient data that matches case report trigger criteria, it will create and send a case report to the decision support intermediary, where that case report would be compared to more detailed reporting criteria that reflects, where the patient lives, where the provider's practicing, and potential state and local public health jurisdictions where the case may need to be reported. So once that match to the reporting criteria, if a match to reporting criteria is made, then the decision support layer will send a case report on to a public health agency where it can process that case report. And I'll come back to that in a moment. You'll also notice at the far right there's a send response from decision support and public health. That allows for public health to send a request back to healthcare. It could be a simple request such as, we need this individual zip code and it was missing from the case report. There may be a simple acknowledgement that the case report was received. In the future, we hope to see more sophisticated responses from public health, and those could include, an outbreak investigation report form that a healthcare provider might help complete, or information on the patient's, residential environment that might influence, care delivery. And then finally, looking back to the process case report activity for public health, it's important to emphasize that this electronic case reporting does not replace or supersede electronic laboratory reporting. What public health would do with these electronic case reports is import them into their electronic disease surveillance system and match them to incoming electronic lab reports that they may have received for that case. Next slide, please. All right, next one. You would just go on. So, what this system is intended to be is, very interoperable with any electronic health record system or electronic disease surveillance system. The decision rules and that decision support layer are designed to reflect the different reporting criteria that state and local public health agencies have. So again, we're just trying to make it easy for providers and vendors. They can simply point an electronic case report to this decision support layer, and it'll sort out whether or not it's an actual report, and if so, or an actual case, and if so, which public health agency or agencies it needs to go to. And it's also designed to be scalable, so additional reportable conditions can be added. As we eradicate disease, we can remove reportable conditions. And longer term, we're trying to design this infrastructure so that it can support additional use cases beyond infectious disease case reporting. The whole system is designed to operate in the background, so we're not interrupting or modifying the lives and practice and workflows of the clinicians. It is designed so that the clinicians can manually send a case report, and it's also not meant to supersede any requirement that they immediately telephone their state and local health department. But this is designed to be a background process, and again, not burden them with extra work. And as many of you may know, electronic case reporting is a new public health option for meaningful use, stage 3, beginning in January 2018. So over the course of calendar year 2017, this digital bridge effort will be looking to partner with at least 5 implementation sites to implement this electronic case reporting solution and help providers in their jurisdictions meet the requirements for meaningful use. Next slide, please. Okay, and I think this gets to this notion of public health speaking increasingly with one voice. I mean, I think public health is recognizing that it needs to increasingly take a unified approach, and we can't keep approaching the healthcare provider communities and the health IT communities with these very narrowly focused use cases on a particular disease, because there's driven by public health programmatic objectives. We need to think more holistically and more strategically. And finally, just to reiterate, the hope is that after we make some progress with electronic case reporting here over the calendar year 2017, we start to take advantage of this collaboration between public health and healthcare and think through more sophisticated or complicated information exchange transactions and how public health might start sending more information-rich data into healthcare systems. Next slide, please. All right, and a quick look at the timeline here. Again, you can obtain this material from digitalbridge.us if you want to look at the details. But this is a very fast-paced project. Particularly on the public health side, there's many people that wanted to be involved, but to really execute the governance and keep it a balanced collaboration between healthcare and health IT and public health, we have had to limit some participation. But please know that through the public health associations and presentations like this, you do have opportunities to send your thoughts to the Digital Bridge initiative. And again, that website can help you find how to do that. Next slide, please. All right, I think maybe in the interest of time, we'll end it there and move on to the next segment.
Hi, I think that means me. This is Heather Howard, and I think hopefully we will move forward to my slides. As was mentioned, did you want us to go through the rest of your slides?
Yeah, I do feel like we need to move on to the next, just to give you enough time. But please know that there'll be additional communications on the Digital Bridge electronic case reporting site selection process. I've got a couple slides here on that, but please know there's more coming, and you can go to that website to find out more. And I'll just point out that this Digital Bridge project is not the only way to pursue electronic case reporting. Ultimately, we do want to help the public health community move towards a more unified approach. But we are looking to partner with about 5 sites to work closely with to implement and evaluate this particular approach. Thank you.
Thank you, Jim. So it's great to follow you and Vivian, and this is Heather Howard, and as was mentioned, I was New Jersey's Commissioner of Health and Senior Services, and now I direct a program of the Robert Wood Johnson Foundation, the State Health and Value Strategies Program, that works with states on improving population health and reforming healthcare delivery systems. And I think we can jump right to the next slide. We produced earlier this year a brief entitled Integrating Public Health and Healthcare, Getting Beyond the Theory. So I think, Paul, that is in line with your call to get beyond the platitudes. And I think today it's already been great to get really granular. I hope that's helpful to the people listening in. And from my perspective, it's I hope to offer a complementary perspective from the view of a state healthcare purchaser. And I want to start with some definitions. What do we mean by public health integration? The way we defined it, and we did in this brief, it's a relationship between public health officials and a healthcare organization, such as an ACO, an accountable care organization, that aims to strengthen the connection between the delivery of healthcare and public health prevention efforts. And I start with that definition because I think many on this webinar will know that historically state purchasers of healthcare, such as, and by that I mean Medicaid or employee group plans, those purchasers have seldom worked closely with state, county, or local public health officials. And that absent economic incentives, health plans and providers have had, unfortunately, little reason to consider the implications of population health. But these are exciting times because that is changing, and there is now a movement towards population-based payment models in healthcare delivery, which is really changing this dynamic, and is what leads me to this slide, which is thinking about how we can use those new payment models to provide more incentives for state purchasers to work with public health officials. And that's why I'm so excited that there's so many people from the public health field listening into this webinar. And I really believe that integration of public health and healthcare would enable those public health officials and clinical providers to work together on what we know are shared goals for population health. So we start with that premise that it makes sense to work together. We can go to the next slide. And then the question is, of course, how do you get there? What are the features of integration? In this brief that I mentioned, we've been tracking some exciting state efforts to integrate health and healthcare, and we've identified what we consider 7 features of integration, and they're not mutually exclusive, but they're components of integration when it works. And I'm going to run through these quickly, and then I have 3 case studies that I'll touch upon briefly too before we get to questions and answers that hopefully add some color to the discussion. So what are these key features of integration? First of all, you can have coordination agreements or mechanisms. Sometimes those can be formal or informal agreements between a public health agency and providers. You can have shared governance, which means you can have public health officials, for example, on a governing board of an accountable care organization. As I mentioned earlier, you can use financing and payment levers. For example, you can have a healthcare entity make a direct payment to a state or county public health department to support staffing or specific prevention programs. Fourth, you can have coordinated analysis and program planning, which it's great that I got to follow the data presentation. You can share data and data analytic capabilities. Fifth, you can have provider recognition and marketing. We know public health, an important tool in the tool belt is public recognition, and public purchasers have certification programs and other ways to publicly recognize collaboration. A 6th feature of integration is the development and implementation of clinical tools and resources, and there's probably no better example than the National Diabetes Prevention Program, and an example of when public health can develop tools for providers and for individuals to guide the provision of care and also to guide self-management. And finally, a 7th feature of integration is provider training and technical assistance. We know that public health can support providers in population health management strategies via training. So those are what we've seen as 7 features of integration. Now I've got 3 quick case examples that illustrate these levers in practice in Minnesota, Oregon, and Vermont. If we can go to the next slide. We'll start with Minnesota. Better Health Hennepin. Many of you may know it's a teen pregnancy prevention initiative that's administered by the Hennepin County Human Services and Public Health Department, and in which they partner with teen clinics, school districts, CBOs to implement evidence-based programs for high-quality reproductive health. And they offer technical assistance to clinics that serve adolescents and young adults, so that's one of those key strategies I mentioned. And they also help promote the clinics that meet the standards they've set. So it's sort of an exciting, for example, they have a website that they created with input from teenagers and young adults to communicate information about sexual health in an age-appropriate, culturally sensitive, and inviting format, and they advertise also clinics that meet the standards they established. So it's an exciting demonstration of different ways you can integrate those key features. We can go to the next slide. That's Minnesota. We'll go west first and go over to Oregon with Trillium Community Health Plan in Lane County. And what's happening out there is that you've got a partnership here. This is Medicaid coming together with public health and it's the health plan in Lane County, Oregon, working with the county together to create a coordinated care organization. And that's a term that is specific to Oregon, but many of you who follow Oregon know that that is similar in some ways to an accountable care organization. But in Oregon, their Medicaid delivery system, they're called CCOs. And what happens there in Lane County is that Trillium pays the county a per member per month fee to actually pay for 3 public health staff positions, which is really, really exciting. Again, that's that point I was making. Sometimes you can even have direct payments. You also have governance. You have the county's senior public health officials sitting on the governance board, and the governance documents themselves commit the CCO to working with the county on managing population health. And the county public health department manages the CCO's community advisory council. So here, just numbers of ways in which they are tied together. And just to give you even more granular, the second bullet, when you look at the numbers, Trillium pays $1.33 per member per month. And so it doesn't sound like a lot, $1.33 per member per month, but it ends up funding three staffers. And one of those positions is an epidemiologist who analyzes public health data with an eye towards identifying the data gaps and working with the CCO, Trillium's data analytics team, to inform intervention strategies. So another exciting example that illustrates these different strategies. Now if we go to the third one, now we'll go back east again, go all the way east to the Blueprint for Health in Vermont, which is emphasizes wellness and prevention through coordinated care across the healthcare system. And it's the state's primary care medical home model, their PCMH model, in which community health teams support public health priorities at the PCMH site. All the payers in the state, and what's so great when Vermont does things, they're able to bring all the payers to the table. So that's public and private, fund community health teams. Public health officials develop evidence-based self-management programs and provide those to give those to providers so that they can be integrated into the practice setting. And they really exemplify how to do sophisticated data analytics to identify those regional public health priorities. If I can go to the next slide, I've got another example from Vermont that I think is exciting, another more info on Vermont. This is an example of the members of their community health team, and it shows you how they work across silos. And their regional collaboratives assist in decisions about the competition of the team based on the needs of the community. But it really shows you how they're bringing people from across all silos and really thinking about all the social determinants of health and how to improve that in the patient-centered medical home. So if we can go to the next slide, I want to wrap up because I want to make sure we have time for questions. But again, from the state purchasing perspective that I'm coming from, at least on this webinar, states have levers to promote integration. The first thing you got to do, of course, is convince the state to use those levers. But one way to do so is to sort of dive in and think about what are these levers, what can they do. One is this: you can structure these reimbursement systems to pay for the population health management programs. We've seen that, for example, in Michigan, the state wrote into their managed care contracts that the managed care companies have to hire a certain number of community health workers per a certain number of enrollees. So it's a requirement that community health workers be embedded in managed care plans. Smoking cessation, of course, is another evidence-based health management program that the state, through its financing mechanisms, could cover. This leveraging managed care contracts, you can go beyond just saying you have to have community health workers. You can also actually, a state could say to a managed care contract company with whom they're contracting, you have to coordinate with public health agencies. And that leads to the third bullet, which is that the state can create opportunities for public health agencies and healthcare providers to apply jointly for state funding. And Oregon has been a leader here. They've actually created financial incentives to promote collaboration, and they periodically have grant opportunities for which a CCO, the Medicaid managed care company, can only apply if they partner with a public health department. So, you know, the state has, that's a tremendous lever when you say, here's a grant opportunity, but you have to collaborate in your application. And then finally, you can apply joint accountability expectations, and the state has a lot of power as in design and implementing measure sets, and just generally with moral suasion. So the state really has a number of levers, and that I hope you'll see that just in those three examples, but those are just the beginning, I think, because this really is the sort of the exciting time when states are starting to see, wow, maybe we ought to do more. We ought to reverse this historic trend of keeping people in their silos, and instead, why don't we come together, align incentives, and really think about ways that health and healthcare can work together. So that's it for me for now. I know we're going to get into a moderated discussion, but I hope I've whet people's appetite with some examples of these integrations.
Well, thanks so much, Heather, and thanks, Vivian and Jim as well for your great presentations. And you presented a lot of information to us and shared some great examples. So while people are kind of formulating their questions, what I'd like to do is just go through a couple of questions that we thought of in advance and kind of give you a chance to maybe restate some of the key points that you were making before. So if we could start out with just kind of restating in maybe a simple elevator speech kind of thing. Why should public health and healthcare collaborate? What's the compelling case for doing this work? And Vivian and Jim, you want to start us off?
Sure. I'll jump in. So national efforts to improve our healthcare system have focused on triple aim, which is better health, improved care, smarter spending. And achieving the triple aim will require health data interoperability, both among providers and between providers and public health agencies. Public health agencies need healthcare data to do better surveillance, and healthcare providers need public health data to provide more informed care. In a case of ECR, public health can share clinical treatment guidelines or outbreak notifications to providers. Ultimately, we hope to see public health sharing information on social and environmental factors as well, so clinicians can treat chronic conditions in a more informed manner.
Thanks, Vivian. And I think what we're going to do is just remind folks that everyone will have access to the slides, because I know you had a lot of rich details in your slides, including kind of how to get back to the Digital Bridge site, but we also know your Digital Bridge site is right up there on the slide that's on the screen right now at digitalbridge.us.
Yes.
And so, Heather, just kind of tossing that same question to you, do you want to kind of restate what you think are the kind of key points about this collaboration?
Yes, thanks, Paul. And in fact, if we can advance the slide, I think I have just a couple slides. We can get off my goofy picture and move on to, so what are the reasons for collaborating? And I think on a good day, I hope that a shared commitment to improving the health of communities is enough. Sometimes it's not. So I think the reality is that often you need to convince folks that working together is going to be more beneficial. If you can work through some of those tensions. If you can go to the next slide, I'm a big believer that this new era of accountability actually provides a burning platform for folks to come together. We have quality targets and cost targets that really that don't allow us to continue in our silos and shouldn't, and bring people together in a way they haven't worked before. And in particular, I think those new payment models get providers thinking, boy, I need to care about upstream non-medical drivers of health, and public health is very well positioned to be a partner in helping them address those non-medical drivers. And I think, especially as these new payment models become more prevalent, there will be that recognition that public health is the perfect partner for healthcare providers as they grapple with these new risk-bearing payment models.
So Heather, as long as we kind of have your points there about these reasons, and you used a lot of state-based examples, we did get a question in from one of our participants that asks us, how can we actually get states to get buy-in for public health integration when budgets are still low at the state level?
It's a great question, because I know that's a constant stress, right, that states are resource constrained. But so I think some of this has to be the business case. And if you're from a state that is not yet in the game here, following what's working, we've got these examples in our brief. We have a couple other examples as well. But following what's happening in other states and how it's working financially to the state's benefit. And as I mentioned, I think you do have this burning platform, especially with Medicaid, with costs increasing and straining state budgets. And so states have to get more creative. More and more states now, the majority of beneficiaries in Medicaid are in managed care plans, so they're in risk-bearing plans. So states have the oversight and have the ability to think through managed care about how to build bridges between providers and public health. And I think hopefully using some of these examples and making the business case and reminding states of the levers that they have. States like to flex muscles. I was a state official, and you like to flex muscles, and I think you can, what's exciting, no matter where you are in the country, you can do so in a way that reflects your local needs, and that, I think, would be the way to pitch it.
And Heather, I know you have a lot of detail in your white paper, in your report. Can you just remind us where to get that?
Thank you. Yes, because I hope folks will feel free to go check out www.statenetwork.org, and that's where we have integrating public health and healthcare, getting beyond the basics.
Great, and I think Jim, you were going to jump in.
Well, yes, thanks, Paul. I just want to point out that the work that the Digital Bridge team is coordinating, reflects this idea that public health agencies could start using shared services hosted on cloud-based platforms, and we're planning on using important work led by the Association of Public Health Labs, the Council for State and Territorial Epidemiologists, and CDC. As well as the ASTO, the Association for State and Territorial Health Officials. I mean, they've been, for the last couple of years, thinking through tools like the Reportable Conditions Knowledge Management System, the AIMS platform, which is used to route messages from healthcare to public health, and we're leveraging lessons learned from the Public Health Community Platform initiative. So that's another good reason to collaborate is, you don't necessarily have to build things from scratch when someone else has already built a infrastructure you can just connect to.
That's a great point, Jim, and I wonder, kind of in that same line, have you guys, or has anyone yet done a cost-benefit analysis of Digital Bridge specifically, or maybe other efforts that are moving data between public health and healthcare?
Well, let me take a stab at that. So I think many people on the call may know that ASTO was leading work on this public health community platform concept, and some of that work has now transitioned to this Digital Bridge initiative. But ASTO did lead or commission a cost-benefit analysis for this shared services, shared infrastructure approach to electronic case reporting. And I think they'd be happy to make it available to the community. I anticipate it'll also be available through the Digital Bridge resources as well, and that study will inform some we mentioned the sustainability work group. that group will be doing some cost-benefit analysis, so we just have more evidence on this topic.
Okay, thanks. That's really helpful. And as long as we're talking about kind of the economics of this and the whole issue of sustainability, one of the folks in the webinar has submitted a question that I'd love to have you guys maybe speculate a little bit, if you don't mind taking a little bit of a risk. But we are certainly all very aware of the changes that are kind of on the horizon with the federal administration change, and we also know that many states' administrations changed with this election. So if you'd like to maybe start, Heather, with any thoughts that you have about, in particular, potential changes to Medicaid, and thoughts about kind of what you're seeing on the horizon at this point. And if you want to defer, you can kick the can.
Well, I wish I had a crystal ball, but I, you know, and it may be too early to tell specifically what's going to happen, but clearly changes are coming. But I think some of the underlying imperatives are not changing. The budget imperatives are not going to change at the state level or the federal level. And so, you know, that we may see things. There's talk, for example, of turning Medicaid into a block grant. But whether that happens or not, states have to balance their budget every year, and healthcare is one of, if not the largest component of every state's budget. And so states are going to continue to grapple with costs, and that's what, you know, I do hope that argument you asked earlier, Paul, about, you know, what's the best way to sell this. I really do think arguing that that partnering with public health is going to allow more effective targeting of limited resources. I think that's still, that argument is going to apply. These issues are actually, these are tough issues to deal with, but these are not actually politically difficult issues to deal with. They're just sort of operationally, you know, so I think regardless of the changing terrain, people need to think about new ways to work together, because the challenges remain.
Great, and I think we're getting some other questions kind of in the queue as well around public health and Medicaid programs, and specifically some of the stories that are coming out about the state innovation models. And I want to just give Jessica a chance to chime in here in terms of the Public Health Innovation Center, knowing that you are working with 3 states at this point that are working at changes in public health, but also I think are interacting with state Medicaid and other state agencies, and wanted to invite you to maybe comment on any of those examples. And then Heather, I know you have been directly involved in some of the SIM programs, so maybe both of you can just kind of talk a little bit about what we've learned from SIM so far, how CDC and CMS have been working together, and then how states have been innovating in this space between public health and Medicaid.
Sure, this is Jessica. Thanks, Paul. I'll start with the latter part of your question and then turn it over to Heather to speak more broadly, I think, to the first part. But through PHNCI, we are working with Oregon, Washington, and Ohio, and I think the Oregon example that Heather gave is perfect and spot on. We're working with them in a broader sense beyond healthcare and public health integration, although that is absolutely a part of it, as they work to transform the public health system in their state. So state, local, and tribal governmental public health, and looking at what they're terming modernization. And they're using a localized version of the foundational public health services in that state to look at delivery of services and what services are delivered by governmental public health and how they should be delivered, and then taking that step further to how that intersects with the work of healthcare and the CCOs in that state. We're also working with Washington, who I know is doing Similar work in that they're using the Foundational Public Health Services model, again, having tailored those definitions to something that is Washington specific, to look at the design of the public health system in their state. And again, a large component in terms of looking at the intersection of healthcare there. Ohio is taking an approach to also look at the Foundational Public Health Services, looking at accreditation and working with healthcare, kind of born out of their SIM grant, to understand how they can better align the community health assessment programs, or not programs, but rather the processes that the health departments are undertaking and that those at the nonprofit hospitals are taking, in terms of trying to align those with both time frame as well as priorities leading back to the state health improvement plan. So each state is really taking a slightly different approach, but looking at how they can transform their system, how they can position governmental public health to maintain relevance, while perhaps considering what services ought to be provided, how those services are going to be provided, and also how those services are paid for. So that's the short answer to a complex question, but let me turn it over to Heather to speak more broadly to the work at the national level.
Thanks, Jessica. Yeah, I think I'm glad you mentioned SIM, Paul, or that somebody asked about SIM, because SIM is the State Innovation Model Program, which is being run by CMMI, the Center for Medicare and Medicaid Innovation at CMS, which was created under the Affordable Care Act. And what's exciting there is that more than half the states across the country have gotten SIM grants to start either planning for, or actually some of the states that are the furthest along are actually implementing new payment reform initiatives. And what's exciting about the way that the federal officials have approached this initiative is that they've really focused on all payer models, creating opportunities for the entire health system to embrace more holistic approaches to keeping populations healthy. And CDC was has been actively involved in coordinating with CMMI, which again, we talk about silos and we talk about silos at the state and local level. That happens at the federal level too, we know. But this is an example of where they've worked very well across the silos, with CDC working closely with CMMI. Now, to tie back to your earlier question, Paul, about changes, we don't know what the future of CMMI is, of the Innovation Center is, but earlier this fall they did a request for information on the future of the SIM program, on state innovation models. And my understanding is there was a lot of comments about states being excited about these opportunities and not wanting to lose momentum. So my hope is that there will continue to be support for states to keep moving forward. Now, there's always the resource constraints, but the fact that more than half the states got some form of funding through this program means they're in the game and they're thinking. And so for folks from around the country, I think there's a lot to be optimistic about states getting in the game and changing their way of thinking.
Great, thank you. And we've learned a lot already from SIM. I think there's a lot more that we can be learning and will be learning. And that kind of points to the importance of kind of looking back as we look forward. And one of the questions that came in, kind of switching back to the digital bridge example, was around the question of what we've learned or are learning about all the effort, all the funding that's gone into health information exchanges. And Vivian and Jim, I'm wondering if you could talk a little bit about, from your experience, from your point of view, how have those lessons from other efforts around data exchange and all the activities in the past several years, how are they being applied to Digital Bridge?
Jim, you want to start that one?
Yeah, sure. Thanks. So that's a great question. It's in my view, it's a challenge. There's many states have emphasized a state health information exchange to be that intermediary, if you will, between healthcare and public health. So all those immunization reports and syndromic surveillance reports are going through a state HIE, And we're taking that into consideration. We're trying to design this decision support infrastructure like RCKMS to be hosted in state-based health information exchanges, or really any information exchange that wants to host it, and in addition to APHL's AIMS platform. We do want to make this approach available to public health agencies and providers that are or prefer to use a health information exchange that they're already connected to. But I think it's been well documented that the business model for health information exchanges is not easy. Many of them are on the decline as federal funding dries up, with some exceptions. But it is a difficult business to be in, and at the same time, you're seeing electronic health record vendors advance their own approaches to health information exchange. So yeah, I don't have any easy answers. We're trying to design infrastructure that can be used in existing HIEs, but can also be available through the AIMS platform.
Thanks so much, Jim. I appreciate that. We've got into a lot of great questions so far, and I don't want to neglect some of the questions that we wanted to explore when we set the webinar up. So I'd like to ask that we go to the next slide that kind of tees up kind of the other end of the spectrum, I guess I would say, because in these last few minutes we've been talking about things that I think, for example, to be in a SIM state and actively involved in some of the SIM programs, you'd have to be pretty far along the continuum of collaboration. But if we think back to the beginning of this webinar, about 2/3 of you were kind of into this practice, but not super far along. So we do want to just kind of think about the early stages of collaboration. And Heather, I'm wondering from your experience in working with states in particular, if you could talk a little bit with us about what your thoughts are about getting started in collaborative efforts.
Oh, it's a great question, because sometimes getting started is the hardest part. And if we go to the next slide, I think I have some suggestions. And I think when you look at some of these successful efforts around the country, what they've done well is they've started with a key area of focus by looking at the data and getting people to agree on where there are issues they want to invest in. And so in Hennepin County, it really started by recognizing that Hennepin County had the highest rate of teen pregnancy in the state, and that was really, that became the organizing principle about the efforts there. In Vermont, it's a broader medical home initiative, but they've seen some real innovation spurred by the increasing number of people experiencing homelessness, and have really engaged their community health teams in that area. So some of it can be, let's find an area of focus where we know we have a growing challenge, and that can help organize people. I think the next 2 points sort of go together too, which is that if you're ensuring broad stakeholder participation in your efforts, that's going to lead to the next thing, is that you're going to better understand the population needs and the barriers to care. And I was struck, Paul, by your chart of networking to coordinating to cooperating to collaborating. And as you move across that spectrum, the more you involve stakeholders, the broader your participation and the better your understanding of population needs, hopefully you're also moving further along that spectrum. Two more ideas, other ideas. One, you need some champions, it's clear, and it's great if you can get them on both sides, and people who can bridge those silos, I like to call them cylinders of excellence, but you need people who can bridge them, and that's not always easy, finding those right champions, but investing in finding those champions could be great. And finally, thinking about how your structures are either promoting or hindering your efforts to advance integration. And I'm struck by the fact that in some of these states like Oregon, public health and Medicaid sit in the same agency at the state level, and that may reduce barriers and actually from a structural perspective help. And many states don't have that kind of a structure, and so you have an added challenge of structural barriers. But think about what are those barriers so that you know from the beginning what you're facing.
Yep. And just to add on, Heather, I agree with everything that you've said. And I know from the Digital Bridge perspective that getting all of the stakeholders on board, we had to come to a common vision and make sure everyone understood the value in the proposition of, bridging this gap between healthcare and public health. And I think if you can find that common ground and there's enough will to move forward on an effort, I think that's the piece in terms of, one of the biggest pieces in terms of overcoming. So I agree with you very much. It's kind of like getting started is always the hardest. And so if you can make some agreements, find the value, and move it forward, that's going to be the key to overcoming it. And clearly there's a big value for public health in terms of getting this data more timely, more automatic from healthcare, and from the EHR vendors' perspective, because we are trying to work to have public health as one voice and not many voices, so that they can make one change or maybe a couple of changes to their EHRs that don't have to be so customized for each jurisdiction. And I think we're still working on that value proposition back to the providers. Public health has a wealth of information, and as providers get more into focusing on population, health management, and social determinants of health, we want public health to be able to provide more useful information back to that provider community to help them manage their patients' health much better and make the outcomes better as well.
Those are such great points, and I wonder for many of us in public health, this notion of collaboration seems to be kind of part of our DNA. And I wonder if both of you can address a little bit more about maybe underscoring what you also think is kind of changing in the environment right now, particularly with the changes with the national and local elections in this past week. Does that suggest the need for more collaboration in your mind, or different partners? What are your thoughts? What's changing?
Well, this is Jim. I don't mind taking a stab at that, Paul. I think I don't know if how much this has to do with the recent elections, but I think it becomes more relevant. I think public health, and I'm definitely opining here, but I think public health needs to recognize that if collaborating with healthcare providers or other entities in the private sector who have strong business drivers, that form of collaboration can and probably must entail compromise, and that means just thinking through, okay, what do we as public health hope to get out of this collaboration, and what are we prepared to give up to get that? And I think an example is this with electronic case reporting is public health seems to have finally gravitated to one basic electronic health case report that reflects over 70 reportable conditions, and with skillful use of technology could be extended to even more conditions. So sometimes that's an example of, I think, many programs giving relinquishing some of their priorities for a data feed in recognition that they're ultimately going to get more data with that compromise.
I think that's a really interesting point and trigger something I was going to say, and I think if you go ahead, I have a slide on this, is, Jim, you're talking about standardized case reporting. One thing I think that's critical to sustaining collaboration is establishing a common language, so maybe broader than just being able to share data, but really, is there a common language for providers in public health, and then can you bring the broader community into that discussion? I think, the most important way to sustain the collaboration, though, is finding sustainable funding, and that's why some of these examples that I gave are exciting to think about. An insurance company providing per member per month financing to a public health department, and then being able to show the business case for how that's helping to meet the healthcare needs of the enrollees is the best way to be successful and to sustain that.
That's great, and I think again, we're kind of moving in this discussion along a continuum of collaboration. What I keep hearing come through, though, is kind of a common area, a couple of common areas, whether we're starting collaboration across sectors or we're trying to sustain it, is that it's grounded in this notion of mutual benefit. There has to be an identification of a common set of goals, and there has to be some degree of benefit for both organizations or multiple organizations if it's a multi-stakeholder collaboration. And that's so key. And the kind of getting to some of the sustainability issues, and particularly with financial sustainability, Heather, is, that's not going to happen right away. I mean, I think this is based on entities led by community leaders being in contact with each other and building relationships with each other, right? I mean, is that what you've seen in terms of some of the examples that you're pointing to?
Yes, I think you're exactly right. I mean, I love your framing of the mutual benefit, but it's also, I mean, you're making an important point, which is that in some ways we're talking about investments that may not bear fruit immediately, and how do you make that business case where you're investing and anticipate making longer-term savings? So you need to have strong relationships to be able to make those arguments. And and the backdrop is so clear. Public health has been underfunded for so long, but I think to convince healthcare to make an investment, it really is going to depend on the strength of those relationships, the ability to speak a common language. I mean, one final thing I will say that I should have mentioned earlier is that one thing, as folks around the country are thinking about how to get started, is also states love to hear what other states are doing and using those examples. States don't like to be outdone by other states, so never, I don't think you can overestimate the competitive spirit of states. So wouldn't it be great if we could get into a race to the top of states trying to innovate here? So on the local level, it is about those relationships and finding mutual benefit. But I think also you may want to be able to monitoring what's going on around the country and being able to point to it can really help you make your case.
Mm-hmm. Can I just add one more notion to this whole collaboration piece, just something for us to think about, because we talk about when we collaborate, we have to have this common value to move forward. And I also want to point out the fact that, collaborations at some point, if it is deemed necessary or it's just a logical kind of phase out, can go away. So, if that common area kind of takes, a life of its own and that collaboration is no longer needed, it is okay to, kind of phase out of that collaboration. A lot of what we're talking about are definitely things that are going to, last for quite some time. But I would also, want to kind of put in the notion of always, reevaluating your purpose and your value for that collaboration.
Such an important point, and that kind of goes back to the question of being clear about what the goals are, having some agreement around measures, having some process to evaluate progress, and then, you're absolutely right that at certain points, some organizational forms are outliving their usefulness, and so declaring victory and moving on, right? Moving on to the next set of challenges and opportunities. So we did, sustainability is certainly one of the key challenges we always talk about in this area. I wonder if each of you want to talk about other thoughts about kind of key challenges. If we go to that next slide, again, some of the questions that we came up with thinking about this area of collaboration. Not only what are the key challenges beyond maybe the economics, but suggestions around how you overcome them. What kind of things that you've seen in your experience?
That's a hard one, so I'll start since I don't have all the answers, but I'm sure Jim and Vivian do. I'm struck by the fact that there's so much uncertainty now, and I think that could be a challenge. And so how do you turn that into an opportunity? You don't want people to stay on the sidelines, and I think this reminder that healthcare is very local, that state budgets really do provide state budget constraints do provide the burning platform. That in state has significant levers at their disposal should they choose to use them. So that challenge of convincing people, even in the face of uncertainty, to stay the course. And I think if you've built those relationships and you've moved across that spectrum from networking to collaborating, then you can withstand the uncertainty because you've built those relationships, and there's a commonality of purpose. So I think that's all the key to it. These other challenges are so, I'm sure everyone on the webinar knows these well, especially on the funding. But this staying the course in the face of uncertainty, is definitely now, I think, is top of mind.
Yeah, this is Jim. I just add, well, I think we've touched on some of the key challenges, at least for the Digital Bridge effort. I mean, it's a challenge for public health within itself to collaborate and speak with one voice, and to make it easier to interface with the provider and IT, sectors, which again are, these are for-profit businesses in most cases, and so that's also a different sector than public health. So, those indicate real cultural differences, and I think it just gets back to restating a higher purpose and thinking more holistically, and I think that's why that triple aim concept has been so successful.
Great points. Well, I am just looking at my clock and noticing that we are to the end of our time here for the webinar. So we didn't get to cover all the ground we had hoped, but it was a very, very rich discussion. I want to thank everyone for submitting questions and for your participation. And if we didn't get to your question exactly, we'll be sure and provide an answer. When the webinar closes today, you will be directed toward a brief evaluation, and I hope that you will share your comments and suggestions because they're very, very helpful and important to all of us. So thank you, Vivian. Thank you, Jim. Thank you, Heather. Jessica, thank you. And I don't know if you have any closing out remarks from the Public Health National Center for Innovation.
Just to add on a special thanks to you, Paul, and to everybody for listening in today. We appreciate it and look forward to seeing everybody back here in December for next month's webinar.
All right, thank you.
All right, you may
Thank
now
you.
disconnect.
Thank you.